Good morning, everyone. Thank you very much. It was very kind of you. Must thank Dr. Garg. Such a fantastic meeting, and his communications are always absolutely fantastic. He and his team. Right. So, actually, the topic of nodo-paranodopathies has become quite big. So, I will have to run through it quickly, and we can discuss a little bit as it emerges later on. But I'll give a little preamble. And the preamble, I think, is quite relevant to the whole substance of this topic. Earlier this year, I gave the same talk to API, same topic talk to API. Of course, you plan it differently. And one old physician came back and said, "So is GBS? Is it just old wine in a new bottle?" So I was thinking to myself, is it old wine in a new bottle? Of course, the bottle is new, our nomenclature is now new, but we're also understanding the components of the wine better. So we progressed a little. Now, what has been the progress? To know the progress, I'll go back a little. What's the history? If we look at clinician neuropathies, clinicians divided into sensory, motor, distal, proximal, areflexic, autonomic, and what have you. So, for quite a while, the clinicians were at the neuropathy game. Then came the electrophysiologist. And for the first time, they said there is demyelinating and axonal, based on the characteristics that the machine gave. And that went, I think, pretty deep in our minds, that there are two basic big types, demyelinating and axonal, and they merge, but they're often exclusive. That stayed for a while. Then came the pathologist, took the nerve biopsies and said, look, these are inflammatory, these are non-inflammatory, these are amyloid, this is this, this is this. So we had demyelinating immune, we had axonal immune, and we progressed a little bit. Now have come the antibody people. And they now said, look, various antibodies define various groups. And another very interesting thing that has happened is, they are saying what the machine shows as demyelinating versus axonal as two very different things are not so different. But the origin meets at the node of Ranvier. And I think this is the crux of the whole thing that I'm going to say. Right. So I will run through the slides quickly. So what's the concept? As I said, it's demyelinating axonal, and we have acute inflammatory neuropathies, and we have chronic inflammatory neuropathy. For a long time, we knew MMN, which is one of the ganglioside-related neuropathies. But we didn't tie up MMN with the whole game of immune neuropathies. Initially, it was defined in cases of axonal variants of GBS with anti-ganglioside antibodies. Now, sorry, I keep flipping back again. Dr. Katrak is here, and as you know, he was studying axonal neuropathies way back before axonal neuropathies actually, axonal GBS actually came into existence. And studying those patients with him at that time, we realized that some who have an axonal electrophysiology don't seem to do very badly. Some do very badly, and some don't. And we didn't know why. And now we know why. Right. So the term nodopathy or paranodopathy is not very new. It's about 15 years old. It proposed, firstly, to characterize neuropathies having a common underlying pathogenic dysfunction at the nodal region and a pathophysiological continuum from reversible conduction failure to axonal degeneration. So both these processes come together at the node of Ranvier, and depending on how severe the immune attack is, they can bounce back or they can continue to go down and become axonal degeneration. And those of you who want to study this further, I think the first two papers are very important. by Antonio Mancini, and second is FEMI. These two are the key papers in the game. Third, what we have done at the instance of Dr. Vinay Goyal, we just got data together to put up in annals. Right. We'll go over this. Right. So Mancini and Kuwabara proposed this concept of nodo-paranodopathy, pathophysiological continuum from transient nerve conduction block to axonal degeneration. I think this is new, that the same process can stop at some point, get better, or go on to become more and more axonal. The second point to remember is conduction block, as we understand, they proposed may be due to paranodal myelin detachment. Now, in our minds, myelinopathy means Schwann cells are being attacked by immune cells, and therefore the myelin is getting denuded. But this concept proposes that where the myelin anchors to the axon, that's where it gets disrupted, and therefore what may result is a myelinopathy, but the problem is at the node of Ranvier. And the conduction block that results from this can be reversible without excessive temporal dispersion. So some people working in the field in electrophysiology have made a point that conduction block without temporal dispersion, CB without TD, is a strong feature of a nodopathy. Right. And for purposes of research, people have divided that nodal region into the node itself, paranode, and the juxtaparanode. And these definitions have been there in anatomy for a very, very long time, actually. The point is, at node, paranode, and juxtaparanode, different antigens have been identified, and antibodies to which seem to produce the acute, subacute, or chronic nodopathies. And as you see here, there is gliomedine, there is neurofacin 186 at the node. At the paranode, there is 155, and so on and so forth. So at the present point in time, which are the nodo-paranodopathies that we know? At the node, the gangliosides. And the results we know, AMAN, AMSAN, MMN. Gliomedine is known to be affected in AIDPs and MMN. And NF186, which does MAN but also does other things. At paranode, you have gangliosides, and you know that the GQ1B for a long time we knew, just like MMN we knew for a long time, MFS we knew for a long time is a GQ1B antibody. NF155, contactin, and Casper1. And juxtaparanode, Casper2 and contactin2. Now see the last point on the slide, acquired neuromyotonia. So the spectrum moves from neuropathy to neuromyotonia. Right. And this picture is from Mancini's paper. I don't know why the citation is gone. It's from Mancini's paper, which shows how the myelin comes off the axon. This is health and this is disease. Right. Now, I think again, I'll skip some slides in between. But here I'll show you a patient of ours who had a reversible conduction block. Now, for reversible conduction block, obviously you have to do serial electrophysiological studies. You need at 0.1 and 0.2 and 0.3. So this is a patient who came with a rather severe quadriparesis. And at day 1, you can see how bad the motor NCS is. And just on the 7th day, you see that they have become better. The so-called reversible conduction failure. Right. Then let me expand the continuum by mentioning that everything related to nodopathy is not in the peripheral nervous system. It also links with central nervous system demyelination. So patients with peripheral nervous system problem and a central nervous system problem are known with a variety of antibodies that are included at the nodal-paranodal junction. And in fact, some of them have MOG positivity. So there is a crossover. Now, there will always be a crossover. And the reason why there will be a crossover is we in our methodology, evidence-based medicine, we catch hold of a marker and then we divide into marker positive and marker negative. But that one marker is not the complete picture of the pathophysiology. It's a marker. They are biomarkers. They're not makers. And that's why you will have a MOG positive and a other one positive and two positive and many positive. And it also reflects in the way our immune diseases are. You have a myasthenic patient about which you had a lecture just before this. Patient gets better, but the antibody remains the same. You have a lupus patient who becomes all right, but his antibody remains the same. So antibodies, their marking ability, the interplay with pathophysiology is still at a nascent level. Right. Now I'll show you some results of some data that we're collecting. The caveat is that it's not a cell-based assay in every patient, but there's a certain number that we have looked at. And the points are like this: half and half roughly, monophasic and relapsing. So relapsing seems to be one of the features. And the clinical phenotypes that we saw are GBS-like, acute onset and then going on to CIDP, proper CIDP, and others. And that's the spread of antibodies to show that they are varied. Now again, this is not cell-based. So as we see more and more and we get access to cell-based, the picture may change. But these are the clinical presentations that we saw in our material antibodies are positive. GBS, recurrent GBS, ACIDP, CIDP, MMN, and atypicals. So what were the characteristics of the GBS patients? They had a very severe disease. Within 24 to 48 hours, they went down and often went on ventilator, quadriplegic and on ventilator. So severe disease, rapid deterioration, fluctuating course. The IVIG seemed to help them. Again, they went down. Recurrent disease. And the disease interval sometimes 3 years, 5 years, 7 years. And pain. These were the clinical features of the group that had GBS. Then acute CIDP. I'll show this patient. He is a young boy, 6-year-old when we first saw him. And this is how his weakness was going. He had IVIG, he had steroids, he had plaques. And then we finally ended up giving him rituximab. He had 3 attacks, acute quadriparesis with improvement with IVIG or IVMPS or IVIG and MPS. And this is how bad he used to get. He could just barely move his hands. The 4th attack was very different, which was ataxia, tremor, and myoclonus. And that is him in 4th attack. He had a progressive thickening of the roots along the course with a high CSF protein. And after rituximab, he just settled down, and this is him about a month ago. Amazing. I mean, 3 attacks of complete quadriparesis, and this is the way he is today. Then we saw CIDPs. What were the features? Recurrent weakness, a certain degree of resistance to treatment, severe sensory ataxia, tremors, cranial neuropathies, and again pain. Now, we all know that in CIDP, some have tremors and some have a lot of sensory ataxia. Those are the ones where nodopathy is likely. And then other presentations are central and peripheral demyelination, isolated sensory ataxia, but we have just 2 patients of that, and one person who looked like Mad Sam and then became CIDP. This is one lady with central and peripheral demyelination, and this signal also improved after the standard immunotherapy. Now, treatment response. In this set of some 30 odd patients that we have here, the response to first line, IVIG, Plex, and CST, is reasonably good. So half of them respond. Now, I'll make one point here. All of us who practice neurology in India, from time to time, end up giving or seeing corticosteroid being given to what looks like a GBS. Either we give it for our compulsions or it's given by a physician and then you are referred. And at least I have wondered from time to time that, oh, looks as if it's done something. Though I've been afraid to really go any further on that. But I think those who had a GBS presentation, some number of them do improve with corticosteroids when they're nodopathies, and logical because they're antibody-mediated diseases. So perhaps we were not that wrong in doing that. But remaining half require second modulation, third modulation, often rituximab, and about 20% don't respond to anything. Right. So, when does one suspect a nodo-paranodopathy? Clinically, acute to subacute onset, predominantly distal motor neuropathy with rapid progression. I think the rapidity seems to be an important point. Severe disability at nadir, and associated features like sensory ataxia and tremor, cranial neuropathies, and neuropathic pain. And I think all across literature and reviews, these points have been repeatedly stressed. Then associated disorders like nephrotic syndrome. And I recently have a patient admitted with me who had a nephrotic syndrome 3 years earlier and has now got NF186 positive severe GBS-like neuropathy, or IgG paraprotein lymphoproliferative disorder. So associated disorders outside the nervous system. And when you treat them, less response to IVIG, but response to Plex and other 2 is when you would suspect this condition. Electrophysiologically, reversible conduction failure and and other features. Yeah. Radiology, the plexus is thickened, sometimes remarkably so. Right. How does one investigate these conditions? Serial electrophysiological studies. MR neurography can help. Some of them have CNS demyelination, and antibody testing in venous blood. How do you treat them? I think if they're severe, send antibodies, treat with corticosteroids, IVIG, good response, slow escalation, the first line treatment. Less response, Plex. No response, rituximab. This is a proposed algorithm, but there is no algorithm that encompasses everything. Each case is different. Right, so the key points. The final common pathway is the dysfunction or disruption. Both words I put down with thought. Dysfunction, which can reverse, or disruption of the excitable axolemma at the nodal region. To stress that it's a pathophysiological continuum, conduction block can be a result of a myelin problem or an axonal problem, which may be reversible, and you need serial electrophysiological studies. Atypical presentations of GBS and CIDP should undergo early testing of the antibodies. They're less responsive to IVIG, but show good response to steroid, Plex, and rituximab. And patients can have severe disability at nadir, but they have a potential to achieve long-lasting remission, like I showed you in the 6-year-old boy with, I've written here early use of rituximab, but I don't know how early is early. Right. And obviously other monoclonal antibodies will emerge because there is a certain number of people who don't respond to rituximab as well. Thank you very much.